Okay, so let me just give you a quick introduction to Dylan. Now, we are very privileged to have Dylan with us tonight. Dylan is an MD who's not licensed by choice. He is an Amazon bestseller of a book called Sleep Apnea Solution, and he's had a very personal journey with sleep apnea, including having sleep apnea himself, and doing a lot of research into it and how to improve it and different methods of making it a better condition to live with. So Dylan's going to take us through his take on sleep apnea. We're going to follow up with an email for you at the end. So don't worry if you don't miss anything. You will get the chance to have a look at the video again. We'll be putting that up on our website. And also there will be a link through to where you can get more of Dylan's program and more information about Dylan. So I hope you find it really useful and interesting tonight. And with that, I will hand over to Dylan. Thank you, Dylan.
Hello. Can
Yes,
anyone hear me?
coming through loud and clear, Dylan. It's very good.
Excellent. So I'm excited to be here. I've never been on a call where I have the accent, so that's fun for me. Usually it's the other way around. But yeah, so I'm based out of here in Florida, which is I think one of the 3 easily recognizable places in the United States. Here, I would assume. Just like when I think of like the UK, there's like London and the Shire, and I know one of them is real. Not always sure which one.
Well,
but
I'm coming to you live from Edinburgh, so I think
Edinburgh. Oh yeah. So there you go.
We're in the Napiers shop in Edinburgh, which is the capital city of Scotland and some would say the second city of the UK. So
even better, my geographic. There is an Edinburgh. They have a great wrestling program in Pennsylvania. There's that there. But yeah, so today we're going to talk about quite a few things. Do I just screen share now? Is that what I'm doing? Okay, can you see that?
Yes, we can see that. We can see it on your screen. Maybe you want to go full screen or something. I don't know. Or you're zooming in and out. Yeah.
There we go. Okay. See it?
Cool.
Great. Awesome. So yeah, so like I know Simon and everyone has been emailing you, so we're going to talk about a lot of great things here. So kind of the root cause of a lot of obstructive sleep apnea issues here. I think you'll be pleasantly surprised what you see there. And then really getting into the 3-step method here, the A.I.R method, which is a great acronym. Activate healthy breathing, integrate airway strength, recharge the cell. And then we're going to get into some more specific things around that, including like a very key mineral involved in breathing and sleep quality, optimizing tongue placement, and then also, of course, breathing patterns and how they make a big difference over time. So as we all know from American history, this is George Washington. There will be a lot of these jokes, by the way, so I apologize in advance. A lot of this we will spend on understanding the problem very thoroughly, because I know when we go to the doctor, it's like, hey, you have sleep apnea. Sorry, guess you know someone in your bloodline assaulted someone. This is just your karmic path to deal with, and it's CPAP or surgery, right? But there's a lot more going on underneath the hood that we need to understand at a physiological level. So there will be some of that medical science stuff. You have been warned. I know it's like 8 p.m., but I will promise to not lure you to sleep here. And in the kind of the overview getting to that, we're going to go over a lot of the physiological dominoes, okay, that sort of leads us to the moment of having sleep apnea. And then we're going to actually do some exercises here today. When I say exercise, we're not hopping on a treadmill, but some breathing exercises so you can actually measure where you're at. So we'll do an assessment and then also do some exercise, like some breathing exercise around that, like a minute or 2 of that, and then reassess, and you can start to feel that for yourself. And of course, going over the 3 steps there. So like Simon said, I'm Dylan Petkus. That hasn't changed in the last 75 seconds. And for myself, so very similar to probably what you've all experienced, right? First, you start to get a little bit tired in the afternoon. You're like, oh, okay, maybe it's like it's aging, it's stress. But then, like, you kind of hit a point. I know for me, I was pretty young, in my 20s when I started to experience this, of where, okay, I shouldn't need 3 cups of coffee to get through like the first half of the day. Now I'm taking a nap all the time. I wake up every 90 minutes. Maybe there's something going on here, right? And then, I go to the doctor. Um, and then he's like, well, you should get a sleep study. Sounds like a great night. And then I'm not sure if this was back when they didn't really have at-home sleep studies. So I got the full spaghetti on my head. That's all the electrodes and everything else. And got diagnosed with moderate sleep apnea. I'll tell you how the story ends if you haven't guessed already. But given the option of a CPAP, only need a couple nights with that, or I'm like, yeah, I'm not sure. This is it. This is what the the pinnacle of technology was promised: flying cars and sleeping at night. I have neither. And just trying to really push through things. I know, well, my own experience talking to a lot of people, and then also just research wise, you give 100 people a CPAP in a sleep medicine office, you check in with them 12 months later, 60% of them have completely given up on it because it just is not working. And then out of the other 40, only half of them are experiencing benefit. So you push through as someone who has untreated sleep apnea. And for myself, there was a moment because I was in medical school and just going through things and just yeah, life was really hard. So I had to really take things very seriously. Like I was doing some research at the time, messed up a whole big experiment. That was not fun, but I guess you can't lose your job in medical school because you're paying for it. So that was a plus. Well, that's still a minus. So then everything that came out of that moment of desperation, we're going to talk about here in terms of what I discovered. But just to, I mean, you haven't guessed already, overcame my own sleep apnea here. Here's a sleep study, make sure I'm all zoomed in here, and went from an AHI 25.7 to 3. Less than 5 is not sleep apnea, all right? The goal is not necessarily 0. I mean, there's even argument over less than 15 not being a problem, but less than 5 means you're clear. And that's been the case for a lot of people. I know there's questions of like, can you fix this? Yeah, you can. Here's all these people. Here's some of their sleep studies. So like 35 down to what do we got here? 2.7, 51. That was fun. Down to 4.5, and then those are the ones I have in there. So that's where we're at, and we're going to show you kind of the in between here. And of course, I know Simon already said it, but I like to always reiterate, this is Edgar, the educational porpoise, and his purpose is to tell you this is for educational purposes only. Quite the tongue twister there. Always talk to your doctor before making any changes. All right, so very first thing here. What the heck is going on? How do we get sleep apnea? If you want to in the chat, why do you think we have sleep apnea? Either what are you told, what have you researched, kind of where are you guys at with that, so I can kind of base my lectern off of that there. Whether you've been told it's because of weight, because of a big tongue, because menopause, that's a good one. Well, it's a good example here. BMI, body fat, old age is another good one. It's the snoring. Yes. So a lot of the classic ones. So if modern medicine can pin it down on let's blame your hormones, let's blame your body weight, let's blame your age, that's what we'll go for. So there's a series of dominoes that happen and lead to people having issues. Now, some of the things you're mentioning, sleep position, weight, tongue tie, those will contribute. But as we'll see, there's people who have these issues, and then they're still sleeping fine. So the first domino, which is somewhat optional, not everyone has this, we'll talk about this, there needs to be, or in some cases, some sort of anatomical narrowing. Okay, this is what every doctor will say. For me, that's what my doctor said. Is like, well, you got a little, high arch palate, some limited space in the back, thick neck, etc. Just something out of these, like, what do we got? 11 different anatomical things here. Something can cause some sort of narrowing. And if you have, like, say, like extra weight, that will just make the narrowing, because like when you lay down, that'll press down on these airway tissues here. So there's some sort of narrowing. Now, I do want you to know, though, if you ask, because one of the questions like, well, what if I have this or that or that? Can I still have sleep apnea? Another way to ask that question is, what percent of obstructive sleep apnea is not related to a narrow airway? Good question. So I'll have a lot of papers on screen. So if you want to screenshot these or just write the titles down, if you want to dive deeper, I encourage you to. Don't believe everything you see online. I guess is the lesson. I always like to teach people to look at the research themselves here. And so this paper, basically this is like the main finding of it here. Very excited pie graph here. It's about 50-50 of all obstructive sleep apnea is tied to an easily identifiable narrow anatomy issue. The other 50% is not. And yes, Gail, this would include narrow nostrils because your airway is as strong as the weakest link, whether it's your nose or the back of your throat. All right, that's a good question. And then the other thing, because I'll talk about it a little bit later, what would you guys guess the cure rate of surgery is? All right. And this can be, we'll just lump them all together. Jaw surgery, they take out your tonsils, they take out your uvula, they do this stuff. Type in the chat what you think that would.
40%?
40%?
Yeah, I don't know. I had
Okay.
my tonsils removed. I remember I snored less after I had my tonsils removed, but I don't know.
40%, 15%. Gail, very pessimistic. I get it. So it's about, so we got 30%. Good. So, and there, you do get points later, everyone, based on your answers. I'm keeping track of everyone. They're redeemable for something. And it's about 50%. There's a 50% cure rate. Now, cure rate also, this is why you have to look at the literature. Cure rate means you had a reduction of symptoms by at least 50%. All right, not you're 100% better and now you're running triathlons. It means you had at least a 50% reduction. All right, so if anatomy was the only problem and you literally remove the anatomical issue, why is it not like approaching 100%, right? Just for food for thought there. Now, the second domino, which will happen if you have an anatomy issue. So if you're in this half, right? And this will also happen if you don't have an anatomical issue. So for instance, I think we had menopause in here. There's many different conditions like autoimmunity, cancer, diabetes, these chronic inflammatory conditions are often associated with sleep apnea, right? So we're going to tie this back to the original research here. So this is 1953. Okay, I think this was about 20 years after the dinosaurs walked. And what they found in this research was that if you make study participants, breathe really fast at night, it will actually collapse their airway. So if this sounds like the exact opposite, that's what that should sound like. Okay. The hyperventilation will precede a closure in the airway. And then, yes, there will be more hyperventilation, and then it becomes this cycle here. Now, the reason this happens is because, and here's a more recent paper from 2022 talking about like kind of the pathophysiology, the physics, the physiology of this, is that airway inspiration, when you breathe in, will trigger collapse of the airway, just like this like suction force. If you've ever driven around with important papers in your car, and if you had the windows down and they fly out, that's what that negative pressure is basically doing. It's pulling things into the wrong place. Now, if there's an anatomy issue, the reason this develops, because this can develop from like inflammation, hormone changes, etc. But for anatomy, what will happen is you'll have some sort of narrowing, right? But then what happens is you have to breathe a little bit faster and a little bit faster over time to get the same amount of air. And now you have this bad breathing pattern. That's the second domino. This is why many people who get surgery and they're not better afterwards, it's because this breathing pattern is still there. It does not auto-correct itself. You have to retrain things. And that's what we're going to talk about here today. And here's a diagram. Basically, you breathe in fast, and if you see where this like circle is, this little cutout circle, that's the spot in your airway where the tissues will pull together and close off. And this will happen, like if you have a narrow nasal passageway or a big tongue, whatever, that will still lead to the fast breathing pattern and cause this blockage in the back of the throat. All right, that's what's going on. So bottom line here, breathe fast, pull airway shut, bad. Okay. And I went over this a little bit early here. So yeah, we already talked about surgery not being the end all be all. And the way I like to think of it is like, for instance, my mother-in-law, she moved to a new place, and the very first day that they were like, after they closed, the toilet broke and they weren't there, and they came back a day later. You don't need to be an engineer to know what happens over time. So the place was flooded, fixed the toilets, but now they have this secondary issue, all the mold underneath the floorboards. All right, just because you fix the toilet does not get rid of mold. Same thing with the anatomy and the breathing problem there. All right. Now, domino number 3. Now we have a system-wide failure. Because we have a bad breathing pattern, okay, we can get through. But the thing is, let me ask now. So back when you were younger, you could get away with a lot sleep-wise. You could stay up for 4 hours and like the next day be relatively fine. Now, you have to follow your easy 22-step routine, and if you get 13 minutes less sleep than you do on average, you need to call in the National Guard and get off of work. It's just like a disaster. Okay. So what's going on here is that when you have suboptimal sleep, over time, it'll chip away at your body's ability to be energetic, vibrant, and work properly. So that's what the system-wide failure is. So the first to fall in the system-wide failure will be the muscle cells in your airway. Kind of makes sense, right? That's where the main trauma is happening. So here, in a very fun study, they punctured the muscles of people's airways and looked at them underneath a microscope. Very pleasant. They're very painful to do that. On the left, we have someone without sleep apnea. On the right, these are muscle cells, by the way. On the right is someone with sleep apnea. Do these look different? You don't need to go to medical school for 4 years to see that. On the right, because like if we think of muscle cells, they should be like tight, they should be close together. Cool. That's not what we see for the obstructive sleep apnea patient. We see these big globs, they're not tight together. What's going on is like the constant stress and inflammation is now making the muscles in the airway kind of spread out and not work properly here. All right. And it's these muscles in particular that will make them floppier, and then they're more likely to get pulled back. All right. That's the first part of the system-wide failure. But wait, there's more. Just like I'm not sure if you guys have QVC. That's like our infomercial thing where they sell like scarves at like 1 a.m. So what happens then, now you're breathing really bad. And as a result, inflammation, right? All these free radicals, all these things will then go to all these different places throughout your body. If you have sleep apnea, it is really hard to lose weight. Well, that's because your fat cells are heavily inflamed. Sleep apnea, what are the top things your doctors will say? Like if you don't wear your CPAP, your heart's going to explode. We'll talk about that in a moment, in a hopeful way. That, yes, because there's a lot of inflammation in the heart, the arteries, also in the brain fog, dementia, all that goes up because of this wildfire of inflammation that then proceeds from sort of the all the damage that accumulates. So what this looks like as a cycle, because this is pretty hard to get out of, you have a bad breathing pattern, and then a weakened airway, and then the weakened airway will lead to more damaged cells, and then guess what? That leads to a bad breathing pattern, and so on and so forth. So it becomes a cycle where people have this for like 20, 30 years, and then it's pretty hard to get out of, unless you know what we're going to talk about here. So as I scroll up, if there's anything painfully unclear, you want to put that in the chat. And I'm sure if you type it in there, there's probably at least 3 other people who have the same question. And they'll be like, oh my God, thank God for John. He's my savior. This is how I kind of like peer pressure people asking questions. Okay, so no questions, explained perfectly. Thank you. So that is kind of how things fall apart. So we're going to focus on rebuilding that. And one of the best ways is to start with breathing, because it is the primary problem. It is the easiest to fix. It is the fastest response time, because our other options are improving cellular health. Okay, sounds cool. We'll talk about that. Improving the muscles. All right, it takes time to improve muscles. Your breath you can change pretty quickly, so that's why it's kind of the first one. And if it's like the only takeaway you have from today, let it be that. All right, so John asks, is my blood pressure linked to it? Yes, absolutely. Yes. Number one thing, if you have sleep apnea, your blood pressure will go up, because, like, think about it like this. If I emailed you every hour that, I don't know, what would be something really stressful? Your heater's broken and it's the winter. You're going to get stressed out. Your blood pressure is going to go up. Now, if I sneak into your bedroom and wake you up every minute, is that stressful? It's creepy, but also very stressful. And so your body is going to respond to that with your nervous system going up, blood pressure going high, and also like electro abnormalities like atrial issues, etc. And Kate says, if you can tolerate CPAP, does it help? Yes. Yes, it will, if you can. I would say it's still like suboptimal, but it is definitely better than absolutely nothing. But we'll talk about some other ways people have benefited from. So the whole premise of the breathing part, right? We had this bad pattern. I gotta zoom in here. This all happens because the brain-breath connection. This is the same concept as muscle memory. Once you learn how to ride a bike, you don't really forget. I've been told. I don't know. Assume it's pretty true. I haven't tested at 10-year intervals or whatever. And that's because your brain and neurons hook up to your muscles and behave in a certain way. How you breathe relies on muscles, your diaphragm, right? And that signals to your brain like, this is our breathing pattern. So when all those dominoes fall apart, you go into a bad breathing pattern, but we can retrain it by doing things in a different way through the good old principles of neuroplasticity, which just means doing something over time and causing changes in your brain to do something different here. So how we're going to first assess this here. This is something called I call it the relaxed pause, because I think it should be relaxed. Other times it's called the controlled pause is one name, Bolt score is another name, basal breath hold test is another one. I'm sure there's another one I'm forgetting, but it's the amount of time you can comfortably hold your breath after an exhale. All right, amount of time you can comfortably hold your breath after an exhale. If this is lower, which it will be, all right, that means you're going to have a faster breathing pattern. You're going to have more apneas, more snoring. If your pause time is higher, you have the opposite. All right. So that's what the graphic, I think this is also hanged in the Louvre or something like that, but that's what that represents. So we're actually going to measure this here together. I am going to explain it first, and then we're going to do this together. So obviously, if you're operating heavy machinery for some reason, you're on a tractor at 8:24 at night. So you're going to breathe in, you're going to breathe out, and then you're going to hold your breath. And then at the first sign of air hunger, you're going to breathe again. The amount of time you can hold your breath comfortably is your relaxed pause time. All right. Now, what is air hunger? You pause after the exhale. So it's inhale, exhale, hold. Air hunger is when you start to have like a feeling, for me, you have like a feeling of warmth, if you will, in your chest, just like that first little bit. It's not like a physical, sometimes people feel like a rebound sensation or something like that. It's not that. It's like a kind of a warmth. That's from like the chemical reaction, vasodilation, and all of that. All right. So, and this is a skill. If you haven't done this before, that's fine. It may not feel right the first time, but if you do it and you can breathe normally afterwards, like you're not huffing and puffing, that's correct. But if you do it and you didn't feel any discomfort whatsoever, that means you underestimated. All right. So it doesn't. You can breathe through your nose or through your mouth for this measurement. All right. So again, I'm going to tell you what to do, and then we're going to do it together. So again, the instructions are inhale, exhale, hold. And I will say inhale 3, 2, 1, exhale, and then you'll hold. Do not do this. Okay, this is not breathe your last breath, blow out the birthday cake candles. It is gently in, gently out, hold, and watch the timer. And then when you have that first sign of air hunger, first feeling rather, note the time on the screen, write that down. You can even type it into the chat. Actually, I'm going to require you to type it into the chat here. So we're going to start inhaling in 3, 2, 1. Inhale for 3, 2, 1. Exhale, 3, 2, 1, and hold. And so when I first started out, I was around here like 7 to 9, which is a starting point. I would say a lot of people are around, like the majority of people are around 10 to 15. As we get to 20, that's typically the upper end of normal for people with this issue. And then if we're getting beyond 30 and you have sleep apnea, I am more suspicious that you've done it wrong than anything. So I'll go ahead and pause the timer here. So what kind of times we got here? Chris, who is very precise and must be an air traffic controller, 15.12 seconds. 9.5, 12, 13, 15, 12, 29, 23, 35, 32. So for anyone, if you did, Annie, you're writing on my screen. Get out of here. If you did it and could breathe fine normally afterwards, it's good. If you're finding you need like a lot of compensatory breathing, if you're asthmatic, I would just not do this at this point. You want to take it easier. But if you got higher on it, either you push yourself too hard and you had to breathe faster afterwards, or you held your breath after an inhale. Gail asks, does this have any relation to Buteyko? I never pronounced it correctly. So it's the same concept. Theirs is the controlled pause. The only difference in instruction, I would say mine is usually people will measure lower because I'm like really like first sign, because Buteyko, however you may say it, that has a wide range of applications, like from people who are asthmatic to people who are like, I want to run marathons faster. So my crowd is typically, we're just trying to work on this problem at night. So it'll be a less intense measurement. That's why I call it relaxed. And then also, I make a way easier progression to allow people to follow. Because with that, Buteyko, I can't say it right. It's a lot of skill required to do it correctly here. Okay, so the minus 10 points to whoever. Wait, no, points restored for you there. All right, so alrighty there. So that was your time. Now we're going to do a breathing exercise. So hopefully you wrote that down. And oh yeah. I should mention. So usually when first starting out, first big goal is 30 seconds. At this time point, about like 70% of the improvements will be there. And the second goal, because I can never let you feel a sense of satisfaction and completeness, the second goal is 45 seconds. And at this time point, usually about like 90, 95% of breathing abnormalities at night are resolved. And 60 seconds, I mean, I don't think really most people will get much more benefit from that. All right, so we're not going to do jazzercise, just a fun image. So what we're going to do is a little exercise here. And it's going to be pretty simple. You're just going to listen to what I say. And we're going to breathe exclusively through your nose. And it's going to be in for 4, out for 4, and then I'm going to increase the time of the hold, and then we're going to circle back to a relaxed pause measurement and see how things changed. All right. So, what was the lowest one? Alrighty there. All right. So inhale for 4. Like inhale with me. 3, 2, 1. Exhale for 4, 3, 2, 1, and hold for 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Inhale for 4, 3, 2, 1. Exhale 4, 3, 2, 1. Hold for 14, 13, 12, 11, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Inhale 4, 3, 2, 1. Exhale 4, 3, 2, 1. Hold for 16, 15, 14, 13, 12, 11, 10, 9. If you need to breathe early, you can always breathe early. 7, 6, 5, 4, 3, 2, 1. All right, just breathe normally here. Okay. A little exhale here, and then we're going to repeat the measurement. So if you need to scroll up and look at your time again, I would advise that, so you have a baseline of where you are. Okay, so we're going to do the same thing. Inhale, and then exhale, hold. So on the count of 3, we will begin inhaling. 1, 2, 3, inhale for 3, 2, 1. Exhale for 3, 2, 1, and hold. All right. So what we just did, a very quick little exercise, barely for a minute here. And again, note when you have to breathe again. And what that does, it increases your body's tolerance to CO2, and that will improve your pause time. And that's actually what's part of rewiring that breathing pattern. All right. So if you're noticing, you probably, one of two things will happen. One, you're probably at the same, maybe it's easier to, when you like get to that level, maybe you gained about 1 to 3 seconds on that. Either way, that is like the very short-term response to your body being more exposed to CO2, because that is what your brain responds to with these breathing exercises. All right. So, and that's what leads to the long-term adaptation there. So here we go. Okay, so we got increased by 3 seconds. I guess I didn't do a big Excel sheet. So the thing is, 1 minute is like a snapshot. Usually I'll have people do like 2 10-minute sessions a day. So if you have remained the same, do not fret, all right? Don't panic. Excellent. So overall, mostly good here. So for asthma, you want to follow the standard recommendations from your GP around like when inhaler use is appropriate. Typically for people with asthma, I'll have them do they benefit more from people doing like very, very gentle ones and then gradually building up with time here. Okay. So the idea is, if I find myself where we are here, yeah, this kind of demonstrates it. So like what we just did, we went like, if this represents our relaxed pause time, like we just spent a minute doing this, it went up. Cool. If we checked again in 5 minutes, guess what? It's gonna go back down. Okay. And the idea is the more you do this, that breathing pattern will be more sustained and kind of wired in, so that you're on this timeline instead, where it steadily goes up and up and up. And when your pause time goes up, you go from that fast breathing pattern to a slower breathing pattern that allows your airways to stay more open, right? Because the whole issue fast breathing pattern, pulling things in, not good, blocks things off. So if the issue is fast or regular, the solution is slow and steady, and you do that by basically practicing slow, steady breathing throughout the day and over time. All right, cool. All right, so that's the breathing there. Well, we're going to do more of that. Does it help with snoring? Yeah, so snoring is a partial obstruction. Sleep apnea is a full obstruction. And this may blow your mind, but you must close a door partway before you close it all the way. That sounds like a Chinese proverb there. But yes, that's why this will help with snoring here. So we just did the first step here of the A.I.R method, the activate healthy breathing. I'll kind of, I guess, talk a little bit more about that here. So, oops, trying to zoom in here. Yeah, so like I was saying, we corrected from corrected from like fast to slow in a short time scale. But the way I want you to think about this is because over time, you want to progress the exercises. So like with Alex, he's asked a few times, and this, I mean, everyone is going to have a different starting point, as you saw with all the different numbers in there. All right. So there's going to be different exercises that will be appropriate. And I think of the following milestones, and these are milestones. Okay. Just like if you were to try to do like push-ups, right? You have milestones. Can you do push-ups against a wall? Can you do push-ups on your knee? Can you do regular push-ups? Can you do one-handed push-ups, right? There's a progression. Same thing here. And being able to master each of these stages, which will be doing it for 10 minutes, that's what those milestones are like, right? So like being able to do 10 in, 10 out just for 10 minutes. And then to answer Mr. iPhone is then increase the time of the exhale. So 4 in, 12 out, right? And then from there, I call it like a 7 box. So it's like box breathing, but like 7 count inhale, 7 count hold, 7 count exhale, 7 count hold, repeat that. And then from there, the next milestone is 5 in, 12 hold, 5 out, 12 hold. And these get exponentially harder. Don't do all these today. And then from there would be 5 in, 5 out, 30 hold. And the very last one is doing a variation of the one we did, but while walking, which is much, much harder.
Do you do this as a maintenance now? Because I know you said you've managed to get rid of your sleep apnea, but do you continue to do breathing exercises for your whole life?
Yeah, so I breathe every day. I recommend everyone do that. And that was a joke answer. Real answer, no, I don't do any of these exercises. Well, the only time I do them is when I'm explaining them to people, which is pretty frequent. If you want a real challenge, talk while doing these exercises. That's always fun. But I haven't done like dedicated breathing exercises for this, and it's been over 10 years.
So it might suggest that some of the wellness stuff around breathing and meditation and everything does have a physiological benefit then.
Oh yeah. Breath work is a tool for many different things. For like say meditation, more relaxing. For this, we have our one concrete goal of increasing CO2 to rewire breathing pattern. Some people get really funky with breathing exercises and hallucinate. That's out the scope of this conversation, but yeah, breathing is a very effective tool to evoke a physiological response here.
And just on the timing things, you're aiming for a higher time, right? That's what you're trying to get to.
Yep, you want to increase the ratio of times breathing out or not breathing in, so exhales and holds, to the inhales. So like the easiest way to see this is when it's like the first milestone is 10 in, 10 out, so this is even, 1 to 1. And then this next one is 4 to 12, which is 1 to 3.
And stress would cause kind of shallow, fast breathing. So stress could be having a big impact as well.
Absolutely. So like in our program, like there's like people can ask me questions. Like one of the most common ones, most of my job is just getting people to not freak out. They're like, Dylan, my relaxed pause was 17 yesterday. Now it's 15 today. How many hours do you think I have left to live? That's not what they say, but like that's how it feels. And I'm like, okay, like, is there any stress um, in your life? Like, oh yeah, like I was up last night, etc. So when you're kind of stressed out, it will show up in your relaxed pause. So doing like relaxation breathing exercises or just like mindfulness for like 5 minutes can really help with that. But yeah, it will show up there. Um, and Kate, what do you mean freak out? But yeah, that's. And Gail asks, if you haven't done this for 10 years, sounds like you've managed to completely re-educate my breathing patterns. Yes. That's the thing. It's just like the bike. Once you relearn how to ride the bike, you're good. There.
What do you think? Do you have a theory, Dylan, as to what, because you were in your 20s, sounds like you were going through a stressful time at medical school. Do you have any sense of what the trigger could have been that disrupted your breathing patterns, or, you know?
Yeah, so I think it was a lot of stress from the workload. Some narrowing in my airway. I had like a thick neck and all of that. And then also a little bit of like I have like an arched palate that like if that's the roof of your mouth and like it should be a little bit wider. Mine's a little bit more narrow. Also have a little bit of a big tongue as well. Those were kind of the parts of my formula there. So cool. All right, so that's just the base of the pyramid. Again, feels too restrictive, etc. Yeah, it's just take it easy. Take it easy, because if you push it hard with this breath work, it'll put you into fight or flight, and that'll be counterproductive. So doing the easier stuff, just like 5 in, 5 out, just so your body gets used to it, and then your body will relax, and then the breathing exercises are way more effective. So, okay. Number 2, airway strength. Okay, I think we've seen enough diagrams, and so I put it here for a reason. So these muscles will flop back, obstruct, partial obstruction. Thus, if we can move them forward, you can see my mouse cursor, move them this way, it'll be less problematic, right? So if I think of breathing as like the fast fix, the muscles are like long term. They take a little bit more time to have an effect, but it allows for the long term maintenance of this here. So a lot of this, there's a lot of different muscles, all right. But probably the most problematic for people is the tongue, because that's this big old thing here. And a lot of the exercises will focus on getting the tongue up towards the roof of the mouth and out towards out the mouth. All right. And I guess I skipped over my other study, but this is known as oropharyngeal exercises, also known as myofunctional exercises will be another name for this. The research has shown this can be very, very effective in reducing apnea events by about like 50%. Okay. I guess that would count as a surgical cure rate. So with myofunctional things, again, there's a broader, you first want to determine your major weaknesses, maybe one, maybe a bunch of things. You want to work on the motor control of those things. You want to work on the range of motion, and then the strength endurance. Okay, so we'll walk through an example with the tongue, because it's probably one of the most common things. So we've skipped step 0 because we kind of can't do that in a meaningful way on this call. Step 1 is about motor control, because if I ask you like, hey, are you able to have your tongue towards the roof of your mouth? I find like 60 or 70% of people like can't do that predictably, just because like they don't have like the proper motor control of their tongue. So what we're gonna do, just click your tongue. So just like that. Okay, should make some sort of audible noise. Cool, we're doing that. And then you want to slow it down. Do very slow clicks. And slow it down so much that you really start to appreciate that it's like stuck up there on the roof of your mouth. Okay, cool. So what we did there, because one of the best positions to practice, we'll talk about number 3, is to be in that tongue suction position. So do the slow click, but just keep the tongue on the roof of the mouth. Cool. Okay, so that's how you would do that. And then for range of motion, it would be making sure that you can do the following, and you should only do this if you have, good neck range of motion, because we are going to move the neck back and forth. So what you're going to do, try to bring your tongue towards your nose, the tip of your tongue towards your nose, and then what you're going to do is bring your head up and then down while holding that position and going back and forth. All right. Just do that. And like if you were to include this in your routine, it'd be like 3 sets of 20, something like that. And that works on lengthening it and also strengthening your tongue. Because again, the whole thing, we want the tongue up and out, up and out. So you can see we do that exercise. We're working on the out part. All right. And then the last thing, going back to the strength endurance, we'll just be doing those tongue holds. So it's just getting your tongue to the roof of your mouth and just having it there for like 60 seconds or so and doing a couple sets of that. All right. So that will allow you to basically, like we said, be able to get the tongue up and out as opposed to falling back and down. All right. And again, you may find the tongue exercises are amazing. You may find they do nothing for you. That's because there's a whole a lot of things around myofunctional exercises. But I would say the tongue is, I mean, I picked that one because it's the most beneficial one for people there. All right, so that's the I of the AIR method, integrating airway strength. And then the last one, the home stretch here, recharging your cells. So I saved the most complex physiology for last. So in case your eyes are glassing over,
Sorry,
take a couple
Dylan, is there's like different angles to come at this from, all of which are connected, and any one of them can trigger off the cascade, which then gives you the insufferable sleep apnea, which progressively just makes things even worse.
Yeah. So if we go back to our little spiral of sleep apnea here, right? So the bad breathing pattern, we're addressing that. And then we also want to address the weakened airway, because if you have a okay breathing pattern, but really weak muscles, you're going to have a problem. But if you have an okay breathing pattern and then okay airway muscles, you'll be much better off. And then the last one is addressing the damaged cells over here. Does that make sense?
Yes, perfect.
Cool. All right, so last one, and this is why a lot of, remember we said it's kind of 50-50 with like pure anatomical versus, hey, you're stressed out, hey, your hormones, hey, you have mold in your home, right? A lot of people can develop like sleep apnea because they have a moldy home. This is why. So mitochondria, they produce energy inside your cell. We're going to skip about 30 years of science. And when they produce energy as a byproduct, they also produce this. Okay, I'm zooming in on it, not just because I want to show off how pixelated it is, but carbon dioxide, when have we mentioned that before? That's what tells your brain how to tell your body how to breathe. So do you think, for 500 Petkus points, do you think the thing that produces the substance that regulates your breathing, do you think that might be important? Correct answers include yes, yeah, definitely. Yes, Dylan, you're always right. All right. So, and how that happens, so CO2, right? And then it'll be sensed in different places, mainly to your brainstem. And that's what will tell your diaphragm to pull down.
Dylan, you got a Scottish eye there instead of a yes. You got an eye.
Okay, excellent. So. Excellent there. So, I mean, just the basic bullets. Mitochondria make CO2. CO2 regulates breathing. Now, here's where it comes in. Damaged mitochondria will have less CO2 output. CO2 is the signal that tells our body to breathe. So if we have less of that, we're not getting the proper signal that our brain wants. Now, I haven't said it yet. I keep saying brain a lot here. And I know when you get diagnosed with sleep apnea, sometimes they just hand you a pamphlet. Here you go. You can read it at home. Get out of the office. we've reached our 15 minutes. And they'll say obstructive sleep apnea happens in the throat, central sleep apnea happens in the brain. Partially true. They both happen in the brain. All right, they both happen in the brain, slightly different issues. But with obstructive sleep apnea, that signal is not very good. It's overreacting. That's why you have that fast, irregular breathing pattern. Thus, if we have healthy mitochondria, we'll have steadier levels of CO2 and a steadier breathing rhythm. All right. This is what we talk about when we're like recharging the cells, doing things to really help them out. So you have healthier mitochondria, better CO2 levels, better regulation of breathing, better breathing at night, better sleep, and I think you get the idea. So with this, kind of like three main things to think about besides me not capitalizing the I in inflammation. So you want to reduce inflammation, replete nutrition, and then also restore function. So for inflammation, kind of already went how that goes, but like there's many different ways to think about it. Whether it's like foods, like less processed foods, certain foods are more inflammatory than others, especially around sleep apnea. Like it's a lot of gluten, a lot of dairy. This is a very interesting meal of wine and ice cream over here, but I guess that's the point of the graphic. Things like that. But it not only is food, it could also be your environment, right? You got like mold or like I don't know, you have 3 dogs and you have the same carpet for the last 10 years. Yeah, there's gonna be stuff in there you're breathing in that's gonna cause inflammation in your airway and in your body. Could also be stress, like Simon was saying earlier, that can lead to inflammation in your body, and that'll be not good. All right. Number 2 is replete nutrition here. And I said forever ago that there was one mineral that's probably the most important. Now's that time to talk about that. That's why I put the big red arrow here, so I didn't forget. So, obviously, always talk to your doctor about supplements. But copper is a very important one because it's involved in a lot of biochemical reactions that regulate sleep. Copper usually goes out the window, is used up very quickly in sleep apnea. So out of all of these, I know there's like a bajillion on here. Please do not leave this presentation in order 1, 2, 3, 4, 5, 6, 7, 8. Like, don't do that. Don't do that. Pick one and or maybe pick none. But being able to give your mitochondria what it needs nutritionally, it'll vary per person. Yeah, I have that there. And then the last piece is restoring function, which is just like, think of it as like retraining your mitochondria, which happens a lot of different ways, like aerobic exercise or high intensity exercise, managing your stress, having good circadian rhythm, a lot of different things there. So yeah, those are all the
Anything
major.
about is CoQ10? What do you think about that? Or because there's a
Yeah,
lot of talk about that.
I think CoQ10 ubiquinol as ubiquinol is my preferred form, is
Yeah.
great. Just be cautious. Is your blood viscosity a thing you think about or your doctor thinks about? If so, be careful with CoQ10. I know a lot of people have AFib and then they're on blood thinners, so you want to be careful but it is a really good one for mitochondria. I would say on this list, if I was trapped in a Zoom room and had to pick 3, copper, thiamine is a really big one that people benefit from, and then if I had to pick magnesium or maybe magnesium glycinate would be the third one. Oh no. This is tough. I should not have asked myself this question. I would either go magnesium glycinate, honorable mention, N-acetylcysteine, especially if there's congestion involved, like postnasal drip, or you just feel congested.
Okay. And what would be because I know some other minerals can interfere with copper. So would eating certain foods, would that be appropriate rather than, or is it copper nutritional supplement? What's your experience of that?
So typically I find people can, it's really hard to replete copper because
You
copper is
mean
usually found with,
once it's gone, you can't, it's hard
yeah,
to get
once
it
it's
back.
gone. Yeah, because copper will usually be found with its best buddy, zinc, in food. And it's about the absolute amount of copper you have in your body, but also the ratio of zinc to copper. And so zinc will be really high, copper will be low. And if like you have like say oysters, you know, really high in copper, they also have zinc. So like you're adding more copper, yes, but then the ratio is kind of unchanged, which is unfortunate. You could, you know, seek out like super copper rich foods and make sure zinc intake is a little bit lower. Um, but I mean, I usually don't say this, but copper is like one of the ones. I don't have a copper company, by the way, everyone. And me and Simon earlier were like, let's get copper in the, you know, in the mix here. It's just one of those things like I don't really see the needle get moved unless it is taken as a supplement. You do want to take it. It's tricky. You want to take it away from mineral rich meals. Some people, myself included, I take copper, I get like a little like nauseous, just because apparently it can cause like a local detox. Um, but that's if you take like a relatively large amount in isolation, which I do repeatedly, despite my wife saying, "Hey, don't take three." I'm like, "Well, it's just three. I'm gonna forget later today." Uh, and I said N-acetylcysteine, Nicola.
So it's not actually always the absolute amount of copper, it's the presence of copper in relation to the amount of zinc that you've got in the body. So the ratio is the important thing, and that can go out of whack, right? Once your copper goes down,
Yeah,
right?
yeah. So usually what's helpful is people do copper for some amount of time, like 4 weeks, and then maybe they just focus on eating foods that are rich in copper, because they also have zinc along with it. Because most people have way more zinc than copper, just
Yeah.
from this. Cool. All
Well, Dylan,
right.
why do you think? I think a lot of the people who've joined us tonight would have been treated by their GP and the NHS and everything. Um,
Sorry to hear
why do you
that.
think when we go and see a doctor, we're not told this, and we're not told, oh, you should probably try a reboot of copper for 4 weeks, or these exercises are, but and we're given a machine? Is it just because of the slowness of the way research and stuff comes through to frontline treatment, or what do you think?
Yeah, so there's two things. So in medical school, which, you know, really doesn't reflect what happens in clinic. In medical school, like I know people will say like doctors get 4 hours of nutrition or 2 hours about sleep. But if you really look at it, like for nutrition, you guys would be terrified what doctors get. It's just about like TPN, total parenteral nutrition. Um, that's just like IV food. And for sleep, it's even funnier. It's just like you get 11 slides on sleep apnea, and that's basically it. So there's basically no education on it for a GP, a primary care doctor. And then I'm not exactly sure the flow from primary to specialist, and it really varies in the States as well. But in the States, typically it's pretty referral heavy. Like you see me, primary care doctor, right? Like when I worked in a clinic, family medicine. All right, well, I have to send you to the sleep guy. Sayonara. That's the beginning and end of that conversation. Now I did practice in a more rural area, so I had to be a little bit more hands-on. Um, but that's probably what happens in the NHS, where it's just referred to as specialist. But even if like most primary care doctors, they'll just reflex to like, oh, you're snoring, you're tired. All right, let's do a sleep study, and that's basically it. Now, the reason the other things aren't going to be included, like all the things I showed you, are backed by research. Now, maybe there's like 20 or 30 studies on each thing. It's not nothing. People respond to it very well. And if you think it's all a bunch of googly gook, okay, challenge you to do the exercise for 5 nights, and then that's the ultimate test for yourself. CPAP, last time I checked, I think they're approaching like 15,000 different studies. Just because, and we'll just kind of get into this. So, whenever you have a medical device like this, it's very, very profitable. It's like plastic and like a dustbuster that works in reverse. So we can get those out there, and what makes money will fund research to innovate those devices so they can sell different variations of it, and then money goes in. That's the research, and what is researched is what is practiced, and what is practiced is what is researched, so on and so forth here.
So it
Um,
starts to occupy all of the space around sleep apnea about CPAP because there's a CPAP device that's needed rather than you can't sell exercises really. I don't, well, maybe you can, Dylan. I don't know.
maybe we can, but the with the CPAP, because also at the same time they didn't really have any other answer back in the 80s. They were like, well, okay, they did tracheostomies. They just cut a hole in your throat. Not very hard to upgrade from that. So if you've ever been glad you were born a little bit later, now's that time. So then they went to CPAP, and then it's kind of funny because a lot of times people were like, "Oh, there hasn't been a randomized clinical trial and breathing exercises in 10,000 people." Well, if you actually check the original research on CPAP, it worked really well in like 5 people in one case study by the original inventor, and they were like, "All right, let's run with it." Like that was literally what happened. Like there was no like, are people going to stick with this long term? Are there side effects? They were like, all right, go with it. And that's how ResMed was born.
And
So
so that's how we've ended up in a standard treatment of care where people, if they see a sleep specialist in NHS, they're told lose weight, use a CPAP machine, maybe perhaps do some exercises. That's the kind of
yeah. Lose weight is like when your computer stops working and you call IT and like, have you tried turning it on and off? That's the lose weight for sleep apnea. But despite that, for every 10 pounds, for every, oh geez, I guess for every 10 kilograms, see, I'm versatile. Just don't ask me about stone. But for every 10 kilograms, you reduce your symptoms by about 20%. Now, if you're really, really bad and you have 50 kilograms to lose, okay. But if not, a lot of people will lose weight and they're like, I'm a little bit better, but like, what's still going on? So
very interesting to hear about how it all came about.
cool. I have a list of the questions here, so I can go through these here. If I haven't
Yeah,
answered
these
them.
I've got the questions here. So we can go on to questions. And guys, if you've got any other questions that you wanted to ask, put them into the chat now. I think there's a special, we're going to send out an email, but there's a special link you can go to get more information. I think there's other videos or instructions on how to do the exercises, Dylan, on the link.
Yeah, so what that is basically being able to give you a progressive plan over time with the breathing exercises and being able to like uh geez, where was that thing? This thing. So like, yes, we have these milestones, but also like what happens in between is really important, and being able to do that in a way where like you know what to do every single day and just have like easy audio tracks and instructions to follow. Um, that's what is in our program here, the personalized breathing blueprint. And then also you get support from me. So any questions that come up on those other pieces, I'm there to help you out. So you can check that in there the moment I stop scrolling like a madman. Um, cool. Have I done any work with the UK Hope to Sleep charity? I have not. I have not.
Well, it sounds like
So
they'd probably like to hear from you, Dylan. It's been really interesting. So let's go into the questions that we've got. We'll go the first one. We'll take a note of any questions that come in right now. So is there really, I think we've just been through this, but is there really any alternative to CPAP for treating sleep apnea? And do
no,
any of
forget
them?
everything I said the last hour. No, yeah. So there's so many things. Like this is just my take, right? I think because especially if the options are have this thing strapped to your face, and then also like I know we haven't touched on this, but like I'm not sure how it works in your part of the world, but there's a lot of insurance, driving stuff, like if you get a sleep study, you get sleep apnea, you try CPAP, and you hate this thing and can't get it to work for you, now you're on treated obstructive sleep apnea, and you're in a lot of trouble in a lot of different ways. So I think being able to have as many options, call me crazy, I think having a lot of options for a big problem is a good idea. Very radical, I know. So there's what I've mentioned. If you like diving deeper into diet can be very helpful. I know someone mentioned mouth guards, positional sleeping. Um, it's like bringing a lot of things together to help you sleep. Because if you think about like all these things can add like pretty big percentage points, you just got to stack them all together. I wouldn't say there's going to be any one thing that is magical. Sometimes there is. I do not want to get your hopes up, but it's about having a stack effect. Just like if you want to lose weight, right? It's not just diet. It's diet and exercise. It's not just diet and exercise. It's having good sleep hygiene. Same thing here.
So you know of and have seen people who've been on CPAP for a long time and stuff, and have had an improvement by also doing exercises and
Oh
like
yeah,
you've
yeah.
done.
I get a lot of end of the line people. So they've been on CPAP for 5, 10 years. They tried BiPAP. They've gotten Inspire, which is that implantable surgical device that kind of shocks your airway muscles at night. I've gotten people who they're post surgery. They're like, I still can't sleep. Yeah, a lot of meat on the bone here.
So on that basis, can sleep apnea ever be cured or reversed, or is it something you live with for life?
I can give you a very definitive answer in 7 years
In
on
7 years?
myself.
Okay,
70.
70 years.
Yeah. So I think someone asked, like, can it reverse or revert? Uh, I'm not sure how I could actually do that. Or I don't want to. Hey, honey, guess what we're gonna do the next 6 months? But yeah, so a lot of people that like for myself and people who have done the work, uh, follow up with them 6, 12 months later, they're still good. Um, so yeah, you do not have to live with it for life.
Okay. And I'm sure there must be some people who get on great with CPAP and carry on their whole life and just go, hey, that's just how I sleep. But why do so many people struggle to tolerate CPAP? And do you have any, it might not be your area of interest, but do you have any ideas how to make it more comfortable or?
Yeah, so the biggest reported issues are discomfort with the mask itself, whether that is the fit of the mask, the feeling of claustrophobia, being able to keep it on. I would think the number one issue is that the pressures that are selected at the titration study are too high, and then it creates a lot of discomfort for the user, and then like the respiratory therapist, physical, or whoever just doesn't want to adjust it. So like because like when they set the pressure, they do it to prevent like 99% of apnea episodes. But like maximum comfort is typically at like 90% of that. So there's like this trade-off, which I think is a horrible trade-off of like, all right, we're gonna go for perfect, but chances are you may feel miserable while using this. Like, I think more realistically, I think settling for most, like still 90% is still good. I think that's the biggest issue. And then the fit of the mask, for sure, the ability to nasal breathe comfortably without it. And then over time, there will be a lot of things, whether it's like drying out the airway. Use of CPAP does also lead to a little bit of muscle weakening over time. Um, it doesn't make the it doesn't change the breathing pattern at all. It can be noise. There's a lot of different factors. Now, there's some people who get along with it great. I wouldn't change anything. If something's working for you, you do you. I mean, that's the whole point, to get something to work. There are some people who really want to get off of it. That's a different conversation, but I just think it's not. Let me say this: the guy who invented it, Colin Sullivan, it was first invented as like a temporary measure. And there's an article, Salon, Salon. You can go look it up. Colin, and then Sullivan is Sullivan. That's what he says in the article, because they were like, all right, this is good enough for now. We want to do things like physical therapy wise, right? to help these people restore their breathing.
So go on, sorry.
I was just gonna go to the next question, but you have a
Yes,
follow-up?
that's what I was. Our mandibular advancement devices or tongue training exercises is effective CPAP. I think I saw something interesting where you were talking about a study on kind of physical therapy, jaw advancement, and it was quite a small study, but it showed some good improvements as well, right?
Yeah. I mean, if the statistical power is there, it is properly powered. So it depends on your primary issues. So like when people ask, like, does the mouth guard work for everyone? I mean, if every jaw was the same, then yeah. But your jaw is just as unique as you, everyone. That was like the cheesiest thing I could possibly say, but it's the truth. So that's why mandibular advancement devices, some people will love them. Some people will make it like it will feel like your teeth are about to fall out of your mouth because it's that uncomfortable. So they do work for some people. But my bigger beef is if you're not using it, it stops working. Unlike the breathing exercises, stop doing them. You'll be fine. So I don't think they breed resiliency. And the tongue training exercises, oh yeah, we covered that there. Are they effective as CPAP by themselves? In some people, not everyone, not by a long shot. Yeah, and CPAP will be the default, absolute de facto, unless you're working only through a dentist.
And
Uh,
so Dylan, how do you tell if your sleep apnea is improved? Is that just how you feel in the morning, or would there be other signs that you should? So I think I've seen you say that, or seen you write that it's actually pretty hard to lose weight when you've got sleep apnea as well.
What was the original question? How do you know if
Yeah, how do you
you're?
know if it's improved? If the sleep
Oh,
apnea
how
is
do you know
improved?
it's improved?
Yeah,
Okay.
sorry, it's my accent.
Gotcha. No, it's okay. It's okay. I didn't set my ears to this part of the world before this call. That'd be a wild option on Zoom. So, um, I like to think of it in two ways: objective and subjective measurements. I think every single person should have an overnight continuous pulse ox monitor. I have no idea what you would buy in your part of the world. I just don't. Sorry. But something to just see your oxygen levels at night, because whether you're on the mask, you're off the mask, you're using a mouth guard, that is the easiest and most non-invasive way to know how is my breathing oxygenating my blood. And oftentimes when people do the things that we do, they'll see that number go down. It's like golf, you want it to go down over time. Uh, and that's what you would see. And then once it gets below 5 events per hour, that is when usually people will get a formal sleep study, just so mainly they can go back and get the medical record corrected or whatever. And that's that there.
Okay, Dylan, why don't we jump onto some people have put some questions in. Why don't we jump onto them as they're with us right now? And I can see quite a few of these you've really been through already. But are there any questions you feel able to answer from the chat right now?
Let me see. Let me see. All right, we did that one. We did that one. Did that one. Um, we did that one. Best sleep position for sleep apnea. Uh, no, there's not a best one, but I would say the top ones are sleeping on your side. Don't you dare ask me which side, whichever one's comfortable for you. On People write these articles and it's like sleeping at 11 o'clock in this position says you have
Yeah.
anxiety from when you were 13. But sleeping on your side, sleeping prone, like on your belly, has been shown to be just as effective as sleeping on your side. But again, really the major driver of deciding the position you sleep in is your comfort level. Because I don't want someone to be sleeping on their back and like, oh, my neck. What are
Yeah.
we doing here? And then the last one would be uh, being on an incline of some sort, right? Like a wedge pillow, you incline your bed. That's a scenario where sleeping on your back could be fine. Um, that's what I would say.
And
Uh,
sorry, I was just thinking one of the things I was wondering, because I suffered from GERD for a while, and they told me to sleep on an incline. I guess GERD can cause inflammation up in the airways as well, right? So is acid indigestion something to consider, or would that not be your?
I mean, Simon, all the systems of the body are in complete isolation and just never really related. Yeah, so sleep apnea and GERD go hand in hand,
All
or
right.
esophagus in esophagus. So when you stop breathing at night and then when you start breathing again, kind of that gasp, like if you just gasp right now, you'll kind of feel your chest expand very rapidly. When that
Yeah,
happens, that actually pulls up stomach acid.
I see.
And then vice versa, if you have GERD, okay, inflammation just kind of goes like a trail of fire across a bunch of dry wood. It'll travel up. You'll have an inflamed airway, and it's harder to breathe. So you can see how that goes together. So, yeah, GERD, even silent GERD, as it's called, or LPR. Um, Being able to deal with that, if it is a thing for you, is very important with having a incline of some sort, whether it's again wedge pillow or the whole bed.
Okay, and then you've got another one in the chat that you'd like to
We
answer?
got two more. We got three more. Alex says, I agree. I agree with you agreeing with me. And then Christine asks, is CPAP the default? Yeah, it's gonna be the default there, and they'll probably look at you like you're crazy if you suggest other. No, they will look at you like you're crazy if you suggest otherwise. And then Kate, I've been on CPAP for 6 months, but don't feel better. Is that normal? Yes, you are in the silent majority on that problem. No one ever says that, which I feel is not fair around like how people respond to CPAP. They kind of just gaslight everyone, like, oh, if you're not comfortable with your CPAP, you're a bad person and you're not trying hard enough. But for the majority of people, that they don't like it. So I know there's people like on the internet and on Reddit and all over the place, uh, who are like these CPAP zealots. They are a vocal minority, which is fair because they found something that's worked very well for them. But that's not gonna be the case. So that's I would say that's typical, Kate. And then we'll do LT because we just the Christian. I've been on sleep for 5 years. I don't feel much better. Sleeping still poor. So I think CPAP at best gives you like 80% of your best sleep. So there's that. And then the other thing is just being able to breathe at night does not mean you will sleep well. All right. So there's this whole other branch of people who can't sleep well called insomniacs who breathe just fine. And if you don't sleep well because of sleep apnea, oftentimes you will develop insomnia. Okay. It's called COMISA, COMISA. It's like comorbid insomnia related to sleep apnea. It's a horrible acronym because they use like lowercase letters, but it's very, very common to awesome to have that there. It will vary practitioner by practitioner, what is mentioned. Christine, my watch does continuous levels when sleeping sometimes drops to as low as 70%. That can be better for sure. Most important is how many events you have per hour. The reason I'm not freaking out is because sometimes the watches, etc., they're not going to be like the most accurate thing of all time. They're better at tracking events per hour than absolute drops. But if like getting down to the 70s is very, very frequent, well, I mean, you're already going to the doctor on the wait list there. But drops per hour is the most important metric. Cool. I think that's it. I think that's it there.
Okay. Well, Dylan, that has been really great. I think it's also been a very hopeful message as well, that there is an opportunity to try and do something about things. And it's true to say, Dylan, that people who improve their sleep apnea, they feel like different people, new people, right? After they get on top of it. Did you feel like a really improved your life getting on top of it?
Well, yeah. Being able to be awake and drive a car. So kind of a timeline. I'll give you a typical timeline, everyone. So usually I like to talk to people who adore our stuff. I know, dreadful. But usually in the first week, I'll like email people like, oh hey, how you doing? Usually about like 3 days into this, the typical story is like, oh hey, I tried the breathing exercise last few nights and like I woke up and I actually like don't feel like hot garbage, which I know is like a great testimonial, right? Like 5 stars, didn't feel like hot garbage. But it's really like a lifting there, like you kind of lift a lot of the brain fog, lift a lot of the energy, low energy issues, and then from there, life is gonna happen, right? There'll be ups, there'll be downs, but it's like a smooth trend upward. And there are people who like they're 4, 6, 8 weeks in, and whether it's like their partner is like, yeah, you don't snore anymore, like someone like what was it, like someone's yeah, someone's daughter's like, oh dad, like is dad not sleeping in the house anymore, because like I don't hear snoring at night, right? uh Things like that, or just like you can get through the day and not feel like a huge crash. That's typically around the like 4 to 8 week mark. And then 12 weeks, 3 months into that, that's where people are like, all right, I guess this is I guess that's that. Or they just maintain there. So that's the path there. For there. And then someone asked, do I have a website or Instagram page? Yeah, so we do have a website for this. It's apneareset.com/Napiers. You can check that out there. Otherwise, yeah, I'm all over the internet. Instagram, TikTok. Don't go to TikTok. TikTok. The What's the other ones? YouTube. YouTube is a big one. Long form. I mean, wherever there's social media, I am there, for better or for
So
worse.
we'll be sending out an email to everyone who's registered for the webinar, which has got this video and it's got the directions where to go and everything. So you'll get a follow up to really good. It'll be on our website as well. And Dylan, I want to say thank you also for the 150 questions. I think that we got in. I think 80 of them were something along the lines of my husband snores all of the time. So I think you've probably done something for lots of marriages in the UK tonight as well, with all the helpful breathing exercises. So thank you so much.
Of course.
And we would love to hear from people at Napiers if you decide to try any of these exercises and how you get on with them. That would be really interesting to us as well.